Good morning, everyone. I'm Sung Hoon Choi from Cha-Bundang Medical Center. I'd like to introduce our multicenter study of three pancreatic surgeons from three different institutions in South Korea. Title is laparoscopic versus robotic pancreaticojejunostomy in the remnants of the pancreas with a small pancreatic duct following pancreaticoduodenectomy. I have nothing to disclose. To date, heterogeneous technique of minimally invasive pancreaticoduodenectomy have been introduced, including laparoscopy, robotic, and robot-assisted, and laparoscopy assisted. This heterogeneity reflects the fact that the best efficient surgical option for safe MIPD remains unclear. And the soft texture of the pancreatic parenchyma and small pancreatic ducts are well-known intrinsic risk factor of POPF. The present study aimed to compare surgical outcome according to laparoscopy or robotic reconstruction in patients with soft pancreas and small pancreatic duct. Furthermore, we analyzed the learning curve of each surgeon according to surgical approach and also evaluated the risk factor of POPF to illustrate which MIPD platform might be better to adopt in patients with soft pancreas and small pancreatic duct. This graph shows a trend in MIPD of three participating surgeons. Red color is the laparoscopy approach, and blue color is the robotic approach. This is a hard pancreas cases, and this is a soft pancreas cases. Overall, cases of minimally invasive pancreaticoduodenectomy has been increasing. And there is a trend toward more frequent application of the robotic approach among patients with soft pancreas and small pancreatic duct. A total of 429 patients underwent MIPD from October 2020 to June 2000, from 12 to 20. By three pancreatic surgeons at three institutions. Among those patients, 204 patients with soft pancreas and small pancreatic duct less than 3 millimeters was included in this study. There were three types of surgery of laparoscopy and robot-assisted pancreaticoduodenectomy. Robot-assisted means laparoscopy resection and robotic reconstruction. So we compare two groups according to reconstruction method of laparoscopic PJ and robotic PJ. This table demonstrates baseline characteristics of patients. The differences were eliminated after propensity score matching, especially in pancreatic duct size. This table shows perioperative outcomes between the two groups. The operative time was a little bit shorter in robotic PJ group, and open conversion was more frequent in the laparoscopic PJ group, but there was no statistical significance. The post-operative complication rate, including POPF, were comparable between the two groups. We further compared the perioperative outcomes by subgrouping the patient according to surgical approach for the whole procedure. Only a significant difference was identified in the post-operative hospital stay and shorter in robotic PD group. The robotic PD group shows the shortest operative time without statistical significance, and all other outcomes were similar across the subgroup. This figure shows the individual surgeon's learning curve. we performed the QSUM analysis for operative time to assess the learning curve because pancreatic reconstruction would be time-consuming procedure for the patient with soft pancreas and small pancreatic duct. Two surgeons performed both laparoscopic PJ and robotic PJ procedure. Their custom graph of robotic PJ cases reached their first peak cases earlier compared to those of laparoscopic PJ cases. A slope of QSUM graph of robotic PJ cases of surgeon C, who only performed robotic PJ, showed the first peak at the 22nd cases. At the multivariate regression analysis for risk factor of clinical relevant POPF, surgical procedure didn't impact the development of POPF. The surgeon learning curve was associated with a lower odor ratio, but it didn't reach statistical significance. The findings of the current study showed that both the surgical approach of laparoscopic PJ and robotic PJ could be safely applied in those patients with risky pancreas with experienced hand. However, the robotic PJ approach required a relatively shorter learning curve regarding the operating time, suggesting that experienced laparoscopic surgeons could more rapidly gain mastery over advanced robotic technology. In conclusion, ladies and gentlemen, POPF rate and perioperative outcomes were comparable between the laparoscopic and robotic reconstruction groups. However, robotic surgery might help to decrease the operating time and learning curve, reducing the operative burden in difficult reconstruction procedure. Thank you very much.